every head and neck cancer expresses EGFR to some degree. So almost by definition, that pathway is going to be active to some degree in almost every tumor. There are some tumors that completely depend on the activation of that pathway, and I suspect that it's those patients that when you inhibit it, they do very well with those drugs. The majority of tumors have it activated, but they don't depend on it. So there are parallel pathways that are active. There are downstream perturbations or mutations that make EGFR activation irrelevant. And what we need to do is we need to discover those. And there are a few emerging ones that appear to be quite promising, and some of those emerging ones that are targetable. So for instance, one of those pathways is the PI3 kinase AKT mTOR pathway, where if that is activated, it is downstream from EGFR, and it appears to be able to signal independently of EGFR. And what that translates into in terms of clinical, one hypothesis would be inhibiting EGFR in those tumors is going to be almost useless. And what we really need to target in those tumors is the PI3 kinase pathway. And as I said, there are now PI3 kinase inhibitors, there are AKT inhibitors that are in clinical trials, and there are mTOR inhibitors that are actually approved. So that, if we can discover which tumors those are the patients that we may want to put into those trials or treat with those drugs. But that's really the next step. We've tried EGFR inhibitors in this example in patients. We've seen them work a little bit. We now have to take the next step and say, well, who do they not work in? Who do they work in? Why do they work? Why don't they work? And what can we do about it?